For all verified facts, subscribe to our YouTube channel and click the bell icon to get the latest updates.
Hello and welcome. Some 201 million vaccine shots have already been given across India, 159 million first doses, 42 million second doses. So a lot of people have already been vaccinated. All this information for vaccination, pre-registration, registration is flowing through the CoWIN app. Now, this app is obviously what makes it easier for us to reach the hospitals or the centers where the vaccines are being given easily. But equally, there have been some concerns about whether it's as accessible as it can be. And sometimes there are also concerns, which perhaps is not the app's problem, which is the very shortage of vaccines, which is more, as they call, a back-end problem and not so much of a front-end problem. But let's try and understand how this app works and to what extent is it likely to make life easier, and what are the things that people should be focused on at this point, and how could they be using it better if they can. So to understand this, I'm joined by Sewak Sharma, the CEO of the National Health Authority, which comes under the Ministry of Health and Family Welfare. Mr. Sharma is a career civil servant, worked earlier as the chairman of the Telecom Regulatory Authority of India. He was also Director General of the Unique Identification Authority of India, or the Aadhaar project. Mr. Sharma has a master's from IIT Kanpur, a PhD from IIT Delhi, and a master's in computer science from the University of California. Mr. Sharma, thank you very much for joining us. So first question, who owns this app? Who does it belong to?
Well, thank you, Govind, for having me on your platform. So let me first do this initial bit of a correction. You called CoWIN app. Actually, CoWIN is not an app. CoWIN is a kind of platform which actually has multiple interfaces for depending on the role which you play. So, for example, there is a module called registration and appointment module, which is actually a citizen-facing module, which enables people to register on the platform and also search for vacancies. There is another module which is the onboarding module for business for vaccination centers and hospitals, which means that they publish their timetable on CoWIN platform. There's a third module, which is actually vaccinator module, which is used by vaccinators and the verifiers who verify the identity and eligibility of a person when he goes for vaccination. So that's the third module. And the fourth module is essentially a module which issues the digital certificates, which is digitally verifiable, non-reputable digital certificate after vaccination has happened. After the first vaccination, it issues what is called a provisional certificate. Second vaccination, it issues what is called the final certificate. So that's the one part which basically just right. To sort of introduce the CoWIN platform as it is.
Right. Now, the CoWIN app, I'll come at it from a consumer point of view. There is an Arogya Setu app which helps, essentially self-authenticate on whether I have or I've had or been exposed to maybe COVID. Now, that app sits under a slightly different part of the government, but also links to CoWIN, which I will not call an app anymore. But how do the two link, or could they link going forward?
Look, one is a very important part to understand is that the government may be kind of what is called divided into various departments and ministries. However, Government of India is just one entity in a larger sense. So therefore, one is that yes, the Arogya Setu app is operated by the Ministry of Information, Ministry of Electronics and IT. And the CoWIN platform is being operated by the Ministry of Health and Family Welfare. However, as I indicated in the first introduction itself, CoWIN is a collection of a number of applications, and these applications are loosely connected through APIs. That's the architecture which we created. So we have not created a monolithic platform, but essentially a platform which can host a number of applications around it using APIs. So therefore, what we had done, we had initially itself published these API on what is called API Setu, one of the platforms which we use to publish the API specifications. We have also created a document, and Arogya Setu is one of the partner applications which essentially has used these APIs to connect to the CoWIN platform.
Right.
We also have created a CoWIN web page, CoWIN portal, where you can book it through the you can do the citizen facing functions using the portal. So that's the one. In fact, Umang is another platform, and recently, only day before yesterday, we have published an open API policy, which will basically enable third-party applications to connect using the same public APIs. Some of them are, non-restricted. Some of them are restricted. For example, looking at the vacancies is a non-restricted API, which people will be just able to develop apps. And some of the registrations, etc., will be restricted APIs, which will require API key to operate and connect with us. That's the architecture.
Right. Okay. So I'm going to come to accessibility and backend in a moment. But, as we go forward, there are two kinds of people. One is those who have been vaccinated either twice or once, and there are others who've not been vaccinated. Now, those who have been vaccinated, is there any thought on how they could perhaps demonstrate that fact, and which in turn gives them better mobility or accessibility, as is being explored or being done in some of the Western countries?
Excellent question, Govind. Two things. One is, I'm not sure what Western countries have done, because to my mind, they have not had this kind of, digitally verifiable certificate, non-repudiable, which we have had since day one. We have a certificate which is actually, verifiable from the source itself, and QR code can be read through this thing. So that's one part. Secondly, we have also, for example, now Arogya Setu app, which is basically the app which is a partner app, as I told you. Now Arogya Setu app, if it sees 2 vaccinations done, then there is there's a line, there's a ribbon, the green ribbon comes on that, which basically shows that this person has been vaccinated. Similarly, the certificate, the vaccination certificate, also can be downloaded on a mobile, which can be shown. And by the way, in order to ensure that the certificate is compliant with the international standards, we have utilized what is called the FHIR, fast interoperable health resources, that kind of WHO standard. We are aligning our certificates with that. So hopefully it will become, for international travel also, it will be recognized throughout the world. That's how we are going about it. And of course, in the domestic area, if you are an employee and your employer wants that you should have had 2 jabs, you should be able to show that certificate either on Arogya Setu or otherwise independently. So that kind of thing is being done.
And what about domestic mobility, Mr. Sharma? For instance, let's say catching a flight from Mumbai to Delhi, and today, the whole requirement for RT-PCR test, which is fine. But if I am vaccinated twice, how could I potentially demonstrate that in an easy and quick manner?
The same thing, as I said, that this certificate is downloadable. You can put it on the mobile. You can just show it on the mobile. So like you can show your ticket on the mobile. Similarly, you can show it on the mobile. So it's a digital artifact. It's not a physical artifact in that sense. So therefore, it can be digitally used. It can you can keep it in the, what is called your DigiLocker. And your DigiLocker, you can transfer it anytime, anybody requires it. You just have to transfer it to that individual person. You can email it, you can WhatsApp it, you can do whatever. So essentially, it's a digital artifact which is easily handleable, so to say, and it will be accepted by all the airlines.
Right. Yeah. So on the acceptance, the Arogya Setu app is obviously, it's an app, and you put it on the phone, and it's clear that when it's showing green, you cannot fudge it. A certificate, and I'm just a layperson's question, a certificate people may feel, because it's already happened with RT-PCR certificates, that people may fudge. So I'm assuming, and I'm asking that in this case, the way the CoWIN certificate will be presented, it does not have any opportunity or potential to be fudged.
Not at all. In fact, this will basically verify it at source. So it actually, the QR code itself is encrypted, and there is a utility which will be required to read the QR code. And that itself, once you read the QR code, this is very clear that this is a data coming from the source, and it is non-repudiable. So therefore, it's a completely verifiable digital artifact.
Right.
There's no
Right.
question of any kind of forgery happening. Of course, you can always Photoshop many things, but you can't Photoshop this certificate.
Right. Okay. Now let's come to access. You have about 238 million registrations right now, and 201 million vaccines shots that have been given. Now, the number of walk-ins are actually higher, contrary to popular belief, than the number of registrations. So I think you have about 53 or 54% of walk-ins and about 47% of registration. So what does this add up to? How many people are actually wanting to and waiting in the wings for a vaccine shot at this point?
Well, you can put it this way. There are two types of people. One is those who have got the first dose and have not got the second dose. So those figures are also available on the CoWIN dashboard. This is one of the very, very robust dashboard. You should understand that in a country like India, if we are having a real-time data of the people being vaccinated, what kind of vaccines they have been vaccinated with, how many people with first dose, how many with second dose, how many people are registered but not yet, been able to access the platform or get a booking or are in the waiting. So everything is absolutely transparent. So you can see the number of, you yourself read out those figures that 230 million or something people have registered, 210 million people have been, 201 million, I suppose, they have been vaccinated. So now you know exactly, you deduct that number and add to that the number of people who are still to get their second dose of vaccine. So that's the waiting list in some sense.
Right. So tell us about the back end. Now, there are a lot of questions today about where the vaccines are, whether enough vaccines are available, and some concerns, for instance, whether some parts of on the distribution side, which is, let's say, private hospitals, are cornering the vaccine doses. Now, I know that is the platform is not concerned with that specifically, but how do we know, or can we know more about how you are collecting this data about at the source in terms of where the vaccines are coming from and where they're going?
No, you see, the point is that the private hospitals are expected to provide the input vaccines in the part of the onboarding process. So they are supposed to update those numbers. Once the receipt is there, now expenditure is what CoWIN calculates. So it basically means that suppose I got 100 vials and 98 vials were actually administered by a private hospital X, then we know that X has got 2 vials left with it. So this is the way, though we are not supposed to do the stock taking, but the very fact that you received X number and you spent Y number comes from CoWIN and X number comes from your input into the system at the time of onboarding, we can know exactly how much is the stock available with each entity. So that's something which we do. However, the logistics of the vaccine kind of procurement, etc., that's something which is outside the scope of CoWIN.
Right. So you have 39,506 sites that are now showing up on the CoWIN platform. 38,400 are government and only 1,106 are private hospitals. So it's actually a very small number. But do you have a sense on how the vaccine distribution is on the back end?
Honestly, I do not have, and the reason is that the policy, the liberalized policy which the government had announced effective from 1st of May onwards, essentially it says that 50% of the total vaccines will be procured by Government of India, which will be again, of course, supplied to the state government for 45 years plus to be administered free of cost to the people at the government centers, and the rest 50% are to be divided between the state and the private hospitals. So those processes of procurement, supply, logistics, etc., we are not really aware. And
right.
but what I know is that the pressure will ease as and when the vacancy availability overall in the system. Forget about who is getting how much, but overall vacancies in the system, availability of vaccines in the system increases. Then obviously this whole gap between demand and supply will narrow down.
Right. And I'm going to come back to consumer access in a moment. Do you have a sense when you look at the back end and when you see let's say the numbers going up and down in terms of the number of shots that are being taken, Are you able to collect other intelligence or insights on maybe health access or maybe behavior in the way people are taking the vaccines, and maybe extraneous factors like lockdown and so on?
No, we are not. Let me put it this way: the policy which we have made is a minimal data collection policy. So we are collecting only 3 data points from an individual. We are not collecting his address. We are just collecting his name, his gender, and his year of birth. Year of birth for eligibility purposes, and name and gender obviously for identification purposes. And that's about all. And of course, we know we verify his identity, his or her identity from the documents which he or she submits. So that's all we are collecting. We are not getting the address. Number one. Number two, the person is free to get vaccination booked at any place, anywhere in the country, which essentially allows mobility. So, for example, if I took my first vaccine in Ranchi and now I'm in Delhi, which is the second dose falls, the timetable falls now, I should be able to get it in Delhi. There should be a countrywide mobility factored in there. So from a citizen-centric perspective, the whole application design approach has been how we can make the system more inclusive and more easily accessible to the citizens. So that's what it is, and it focuses itself. We are not into function creep. Typically, IT applications get into function creep, whereby they are made for one purpose and then you start doing for others. We built Aadhaar, and many people were saying that you take the caste, you take the place of birth, and you take economic status and BPL, APL, ration card number, etc. We said no. Our purpose is to establish identity of a person and nothing more and nothing less. So whatever are the essential attributes of identity, that's what we will collect. And that actually the approach, privacy by design, helped us in actually coming clean on the touchstone of the Honorable Supreme Court's examination of violation of privacy in that famous case, which actually also resulted into declaration of privacy as a fundamental right. So essentially, we have designed the system only to facilitate vaccination and ensure that all facets of vaccination are taken care of. AEF or adverse impact report and other things.
Right. So again, I mean, you're the platform manager. You're not the health system in itself. But one, for instance, criticism is that did we need a back-end platform at all? We've vaccinated hundreds of millions of children sometimes on one day in the past. Now, what is the relevance apart? You mentioned mobility. We talked about the ability to offer authentication for travel and so on. But what is the other advantage of having a backend? And then the front end, I'm going to come to it separately.
I think it's a very good question. People sometimes also say that it should be an option. Why was it necessary to create such a platform? Now, there are multiple reasons for it. One is, as a public policy or a public health issue, the country needs to know as to which areas have been vaccinated, which are underserved areas, which are not so much underserved. And that's one part. So one has to know the overall numbers. Let's say one can make a case that you don't need to know the individuals who have been vaccinated, but somehow you collect the numbers. That's number one. Number two is, in India, when I get a vaccine one, and this is CoVaccine, many people will not know as to what was the name of the vaccine I took. So they can, take the second, vaccine, some other vaccine. So that's one part. Secondly, we have to collect and know the adverse impact of the vaccine. If there are side effects, we have to capture those informations. Now, I'm sure manual doing of these things would not be possible. It's after all, we are 1/6 of the global population, and therefore our extent is such a huge or large extent. It's a massive program. It's certainly if you look at the numbers, it's certainly the world's largest vaccination program. So that's another part. Third part is that imagine a situation of supply and demand. If there is a skewedness, then if there was not a platform which was transparent and which avoided information asymmetry, then how people will behave? There will be thronging of people at vaccination centers. Somebody will be searching, where is that vaccination? What vaccine is being done? So now this also is very, very important in a country like ours, where people feel that everything can be done by Pervi and Sifaris and other things. So this platform provides that credibility that howsoever high and mighty you may be, you are also in the line. You can't break the queue. So these
Right.
are some of the things which are required. So from a logistic point of view, from an overall management point of view, from a public health perspective, I think this is a necessary infrastructure which you had to have. And of course, this infrastructure will provide a huge amount of value in future. Even if I think there's no harm if polio vaccination, for example, or if other vaccination programs that the government takes, they also use some digital platform so that we know as to which child has been vaccinated. Now we are able to see which person has been vaccinated, what vaccine, and that's important. So I think we should be using more and more such digital platforms. And India is, after all, not a digitally illiterate country. Imagine India is conducting 3 billion transactions per month on payment transactions. India is consuming 10 gigabytes of data per user on a mobile phone. America's consumption is of the order of 4 gigabyte per month per user on mobile networks. India's mobile networks are transporting more data than the mobile networks data being transported in China and US put together. India has got 1.2 billion mobile phones. India has got 700 million, internet connections, 600 million mobile smartphones. So in a way, this is not an India which typically one presumes and one thinks about India, where people are living in some remote places which are not connected. India is a connected country now. We may not have the best internet bandwidth in the country, but I'm sure every phone is a 4G phone now, more or less. I mean, there may be still
Right.
some vestiges of 2G, 3G, but I think broadly the two major operators, this is Reliance Jio and Airtel, are fully 4G. Vodafone is also coming on that part.
Right. Okay. So now let's talk about those. You're right. We have more than 700 million people accessing the internet, including via smartphones. But however, there's always questions or concerns about those who cannot. They may be old. They may be, physically, physically constrained. So what is the CoWIN team thinking on when it comes to these people, including, let's say, those who are not able to or unable to use either the internet or smartphones? Or
Again, an
internet via smartphone.
extremely good question, Govind. And let me also put a caveat that whatever the statistics I talked about in the previous question about the India's digital capabilities or digital connectivity, notwithstanding that, I certainly agree that there is a digital divide. There are people who are more capable and more have access to more better gadgets and better connectivity than others. So I'm not denying that fact. And the CoWIN team from the beginning itself was conscious of this fact. So we built a completely inclusive system. Any digital system, if it is not inclusive, is useless. It should be accessible to everybody. Therefore, what we did, one, we allowed walk-ins. So as yourself said that 53% of the people, or I think it's 57 or 53, I'm not sure, but nevertheless one can use the term that it's a majority of the people in this country are doing a walk-in vaccination. That's number one. Number two, all the common service centers, which are 250,000 in number, they have been connected to our system. So you can do an assisted registration and assisted booking using these common service centers. From today itself, for your information, we are opening a call center operated by NHA, which is actually 1075 toll-free number, which will be able to, through which you will be able to book the registrations, book the slots and also do the registration. Third, we are also ensuring that one phone giving four reservations or four people can get registered on that. That itself is again inclusive effort. Otherwise, we could have said that you can do it on your own mobile. So what about those people who don't have a mobile even? So that's another part. So we are continuously improvising and improving, and also since the beginning we have had this. And now of course the latest policy where we have exposed these APIs, and now third party applications will come and multiple applications will come, and those applications will again probably improve the reach to the population. So I think They will much more, maybe they will much more user friendly, better interface, etc., etc. So we are absolutely, clear that unless the system is inclusive, and you see, there are two kinds of thoughts. One is people say, because it does exclude some people, or because some people are unequal, therefore you abandon the system. That's one thought. Another thought is that the system, because I explained to you, is necessary. So what we should do is to improve the inclusivity of the system. And there, I think second approach is the right approach. You should enable all kinds of systems, hybrid modes to exist, walk-in to exist, reservations to exist, assisted mode, self-service mode. All these things must exist. So that's the coexistence of all approaches, so as to make the most inclusive system is our objective.
Right. Last question. So, some people, I can't say lots, but some people have had problems. For instance, let's say they've taken the first jab and the system doesn't seem to have that data. Now, I'm sure it's not a back-end problem. It's obviously the most likely happened because the person who was entering the data did not enter properly, or there was some breakdown. How friendly is CoWIN going to be, or will it be to correct these problems which people are likely to face somewhere or the other?
Again, an excellent question, Govind. So one is that, as I said, the minimal data requirements. So the only data is name, age, and gender, which I think people should be careful not to commit mistake, number one. Number two, if they get a jab and don't get an SMS, they must immediately be wary of the fact that this thing has not been entered into the system, because once you have a jab, then immediately within few seconds the system sends you a message that congratulations, you have been vaccinated. First, your second thing is do whatever after so many days. That's second part. Third part is, many times people are also responsible. You know what they do? They create an account using their mobile phone and put themselves, their wife, their family members. Then they for some reason create another account by another mobile number, and they put there also these same 4 people. Now we are not doing any algorithmic deduplication at the back end, because people can use multiple documents. You can use your Aadhaar, you can use your driving license, you can use other documents. So therefore we are not doing deduplication, we are trusting people. Now what happens? You got the first jab using the first account, and you got the second jab using the second account, and obviously the second account doesn't recognize that you are the same guy as the first account. So now you are stuck with 2 first dose certificates, and you are saying, oh, I got both doses, but I have 2 first dose certificates. That's not a systems problem. Once you have an account, it's better to go with that account, because that account will have the history of yours and your family members, and it's a digital certificate will be there in that account only. So many things are there. We are trying to create awareness to remove such mistakes. We are also now introducing some systems to correct these certificates, the errors which have happened in these certificates, and I think that will help people. But as you know, in a group of 20 crore, 200 billion people, even if 1% error is there, that also becomes 2 billion. So humanly, it becomes difficult and impossible to change such things. So we are doing certain things algorithmically, and we are also enabling people to do self-correction. But of course, it has to be done in a manner that it is safe. It should not result into some kind of gaming the system again. These are some of my thoughts.
Right. And absolutely last question, because people do ask this. Where does this data sit right now? Is it, it's not physical, but it's digital. Is it?
I will not tell you, because people might, attack that facility.
Okay, but it's safe.
Data is safe. Absolutely safe. Absolutely.
Right. That's a great note to end on. Mr. Sharma, thank you so much for speaking with me, sharing your thoughts and your insights on how the CoWIN platform is going to become hopefully more and more accessible. And obviously, we hope that everyone will get the vaccine shot they desperately need. Thank you so much.
Thank you very much, Govind, for having me on this platform. I enjoyed talking to you. Thanks.
Thank you.